One of the areas that I think we're particularly interested in is using genomic tests in the neoadjuvant setting. And the patient group that I think it's most useful for are these young women who present with big ER-positive breast cancers, lots of palpable nodes, big tumor. Because I think that, if we give chemotherapy to patients who have very low-risk disease by these genomic tests, we're not going to shrink the tumor any. And I think giving chemotherapy all that time while the tumor is in situ maybe not the right thing to do. So you might want to do surgery and then decide on your chemo afterwards based on the bulk of tumor. So in those patients, we do use genomic testing to try and decide whether or not we want to use neoadjuvant chemotherapy or not, because there's some data that it predicts the chance of shrinking the tumor, which is, after all, your goal in the neoadjuvant setting. So I think that that can be useful. If you have a very high grade, very aggressive cancer, then the chances you're going to get a high-risk score are very high, so you wouldn't send it then. It's more in a situation where you would have a patient who has a intermediate grade tumor, ER/PR is 100%, and you really don't know what to do in that setting.